Hello, my name is Angela Kilby, and today I am delighted to speak with you about my research on machine learning algorithms that have been developed to predict and prevent opioid use disorder. These are algorithms trained on rich patient medical history data, which seek to identify people who may be at risk of developing opioid use disorder problems in the hopes of guiding clinician decision making towards only prescribing opioids to patients to whom they can be prescribed safely. A brief history of opioids. In the mid 90s, opioid pain relievers were approved by the FDA for treating chronic non cancer pain. Medical organizations and licensing boards during this period became concerned that the undertreatment of pain was pretty widespread and began to encourage the liberalization of standards and practices towards greater opioid use for all kinds of pain conditions, including chronic pain. However, the scientific evidence on the benefits and harms of this shift lagged behind the shift itself. As it turns out, there haven't been many randomized controlled trials on this, and especially none that have exceeded a year. So research on the effectiveness and safety of long-term opioid use has been mostly observational. These observational studies have found broadly that opioid use is correlated with a host of negative outcomes and highlight both safety concerns, risks to patients of beginning to misuse opioids, as well as concerns that opioids may not even really be all that effective for the treatment of long-term chronic pain. After a couple decades of liberalization, the pendulum has swung back. Concerned that the liberalization in prescribing had gone too far, the CDC in 2016 released new opioid prescribing guidelines, and they represented a major shift in standards. The guidelines stated that opioids were not preferred for chronic pain at all, and if they were to be used, they set restrictive dosage limits. The guidelines were quite controversial, especially among pain doctors and some chronic pain patients. And the AMA had a pretty scathing response, saying that they were devoid of a patient centered view and any real acknowledgement or empathy of the problems that chronic pain patients may face. This graph kind of tells the opioid story in a picture. This is the past 20 years of prescribing overlaid with overdose deaths. As you can see, there was a threefold rise in opioid prescribing until 2011 that was accompanied by a concomitant threefold rise in death. Around 2011, alarm began to spread, and this led to the implementation of a number of public health measures that sought to curb opioid prescribing. These measures were indeed successful at bringing down the prescribing rate of opioids themselves, which peaked around 2011, as you can see. But these measures didn't have a noticeable impact on the total opioid overdose death rate. Rather, it seemed to begin to accelerate. As has been widely noted, the reasons for this sort of lack of observed impact are probably due to a shift in the composition of opioid drugs of abuse away from medical opioids and towards illicit opioids such as heroin. So the story of the evolving opioid crisis over the past 25 years highlights that the causal factors behind the development of any given individual's opioid use disorder can be pretty complicated. Some patients may develop addiction based on a drug that was prescribed to them by their doctor, but street opioid availability in illicit markets are other important factors as well. So the backdrop of this paper is considerable uncertainty in the medical field that's developed over the past 25 years about how exactly to properly use opioids for the treatment of pain. There's been kind of a push-pull, first concern about undertreatment, then concerned about overprescribing. This frustrating experience has motivated a search for better ways to target and prescribe opioids to patients that benefit from them and can be prescribed them safely while trying to avert prescriptions that cause harm to patients who cannot be prescribed them safely. Into this kind of confusing space enters machine learning algorithms to predict and prevent opioid use disorder. The idea being, if a machine can do a good job at telling physicians which opioid prescriptions to avert, they could encourage and allow for opioid prescriptions to people who really need them while averting unnecessary social harms. A quick preview of my paper. I first successfully train a machine learning model that predicts opioid use disorder that is similar to other prediction models found in the academic and commercial literatures. I then study patients according to their machine-determined risk strata in a causal setting where opioid prescribing is broadly reduced, finding that the opioid prediction algorithm does not, in fact, seem to identify or highlight patients that especially benefit from having their opioid prescribing reduced. I discuss, in the context of these findings, fairness concerns that might result from implementing these models into practice by discussing who has benefited and who might be harmed. So to highlight the burgeoning literature that seeks to do this, It started with a sort of what was called a red flag approach by looking for signals in patient medical records, like visiting too many doctors, which might lead to later problems down the line. The modern generation of models, by contrast, uses machine learning methods and big health data like medical claims data, EHR data, et cetera, to construct a rich set of patient covariates that can be used to predict among those who have received an opioid, those who might later develop opioid use disorder problems. It's important to note that these kinds of algorithms are already being implemented into clinical practice. The most notable is in state-level prescription drug monitoring programs. These are clinical databases of patient records that are intended to help clinicians decide when to prescribe opioids to patients. They have a lot of details on their history, like what doctors they've seen. One of the leading providers of PDMP software has actually developed and integrated a proprietary overdose risk score into this software. So when a clinician logs on, right at the top of the patient record, there's an overdose risk score generated by advanced data science and machine learning, such as the algorithms that I'm studying in this paper. What do? I use commercial claims data collected from health insurers, a data set called IBM Market Scan. This is a very large database of commercial employer-sponsored health insurance claims data that is used in a variety of contexts, including for training ML models to do exactly this, predict opioid use disorder. The data set's an individual level panel over 7 years, 2005 to 2012, so it's a period during the ramp up of the opioid crisis. It has about 7 million individuals, which should be representative of about 175 million employed Americans who have employer-sponsored health insurance. This kind of health insurance claims data is really rich. Clinical information can be inferred about patients that's quite detailed. Prescription drug claims, visits to doctors, what kinds of doctors people go to, their procedures, their diagnosis codes associated with each visit, and so on and so forth. What do I do to develop my algorithm? Well, first, I construct labels on whether a patient develops opioid use disorder within 5 years of receiving an opioid prescription. I identify opioid use disorder if they have 2 out of 3 of the following: a medical claim with an opioid use disorder diagnosis code, a prescription for a recovery medication used to treat opioid use disorder. These are drugs like Suboxone or Subutex. Finally, if I see a claim in a mental health or substance abuse facility. Using these criteria, I identify about 22,000 of 7 million enrollees that have opioid use disorder. The features I use to train the model to predict the development of opioid use disorder include basic demographics, sex, age, and industry of employment. In addition, I construct a large panel of clinical variables, 3-digit ICD-9 diagnosis codes, types of facilities they attend, types of providers they see, et cetera, et cetera. To select my cohort for training the model, I follow a common approach of papers in this space, where they select as their cohort any opioid naive patients receiving their first opioid prescription who have never had a previous opioid use disorder diagnosis. From that subset of individuals, the model is trained to predict opioid use disorder outcomes after the receipt of the person's first opioid prescription. So specifically, what the model is doing here is identifying among the universe of patients who've received an opioid for the first time, the characteristics that are most highly correlated with a later OUD diagnosis, opioid use disorder diagnosis. Okay, I want to walk you briefly through the features identified by the algorithm as most important in classifying patients into the development of opioid use disorder versus not. First, we have demographics, age, gender, and industry. More importantly, we have pain conditions, what look quite obviously like chronic pain conditions. People who visit chiropractors, who have intervertebral disc disorder diagnoses, other disorders of the back, cervical region, et cetera, sprains and strains of the ankle and foot. What the model is telling us is that aside from some demographics, the main characteristics associated with opioid use disorder diagnoses is a constellation of other chronic pain conditions and complex health problems. Specifically, the people who are at highest overall risk of being diagnosed with opioid use disorder are people with chronic pain and other health issues. Next, I just present the model's performance. Under traditional area under the curve metrics, you can see that on the left, the AUC is high, reflecting the highly imbalanced sample with mostly zeros. Most people are negative for opioid use disorder, and the model gets that classification correct in the vast majority of cases. On the right, you can see the precision recall curve reflects that at any given threshold, precision of these models tends to be very, very low. That's no matter the threshold chosen. To dive into this a little more, I consider what would happen if you set a threshold or cutoff at some intuitive points. A threshold set at the 99th percentile of the score distribution for individuals would yield around 8,000 true positives and 61,000 false positives. This is a precision of around 11%. What that means is that of all of our people that we have said we should target for a reduction in prescribing, only 11% of those individuals actually were going to go on and later develop opioid use disorder. So we're going to have a really major issue here with false positives. On the other hand, we have 13,000 positives that would be misclassified as false negatives. Only 37% of people developing OUD were picked up by the algorithm at this 99th percentile threshold. The 95th percentile score cutoff does worse and better in the ways you'd expect. It would identify most true positives and many, many false positives for a precision of about 4.5%. But it would get 75% of the true positives correctly classified, only missing about 25%. As a final note, the model performance that I'm documenting here looks a lot like the reported model performance of other prediction algorithms. Specifically, these issues with the lack of precision and having a lot of false positives are quite common. To consider fairness concerns, I use a simple model drawn from a paper that does this kind of prediction exercise, Hastings et al. 2019. They specifically consider balancing the harms of averting an opioid prescription inappropriately against the cost to society of an opioid use disorder case that can lead to addiction, overdose, and death. Specifically, the percentage of true positives among all those targeted must be at least as great as the ratio of harms of having opioids inappropriately averted compared to the cost of opioid use disorder to society. So we have precision of at best 10%. So that means that the cost of opioid use disorder must be 10 times the cost to a pain patient of not receiving an opioid to treat their pain. A lot of papers, including that paper, grapple with concerns about low precision by asserting the costs of not receiving an opioid to treat your pain are low because opioids are not particularly beneficial in the treatment of pain. However, as detailed in the intro, this is a sort of an unsettled issue in the medical literature and a matter of hot dispute by pain patients and doctors. Also importantly, the model assumes that every true positive individual who's been labeled high risk and who would have had an adverse outcome has been prevented from having that adverse outcome. If the goal here is to inform clinical decision-making, however, the object of interest is not actually an individual's sort of probability of developing opioid use disorder, but rather it's their heterogeneous treatment effect of receiving or not receiving an opioid. To do better than clinicians, the machine should identify people who have especially high heterogeneous treatment effects of having their opioid prescription averted. There have been many dimensions of algorithmic fairness that have been explored in the literature. I would classify this potential mismatch between the training of a model to generate risk scores rather than heterogeneous treatment effects as in the category of fairness concerns generated by the inappropriate choice of an algorithm's target variable. Now I turn to a setting that will allow me to identify and investigate this potential mismatch. What I do is I nest my machine-trained opioid use disorder risk scores into a quasi-experimental setting where there was a broad-scale reduction in opioid prescribing that hit most patients. I rely on some of my own existing previous work, which documented that the timing of introduction of prescription drug monitoring program laws created a quasi-random reduction in opioid prescribing because when you were hit by the new laws was determined by the specifics of timing by your state in introducing that program. I use an econometric approach to do this that is common in the economics literature called a difference in differences natural experiment. I'm going to use this broad reduction in opioid availability to find out if individuals targeted by the machine for opioid reduction due to their high risk score, in fact, were the group where improvements in opioid use disorder outcomes appear to be most concentrated. The first thing I want to briefly show you is that the impact of PDMP introduction on the full sample of every patient, there is in fact an impact. So what you can see in this graph and in this table is a broad impact on the overall prescribing of opioids after the introduction of a PDMP across the full sample of patients. The dynamic specification on the right shows an immediate drop in prescribing that lasts up to 4 years after implementation. On the left, I present the point estimate over all periods. For interpretability, I calculate this thing at the bottom, the relative risk reduction. What that says is that there's about a 3.5% reduction in somebody's chances of receiving an opioid after being in a state with a PDMP versus people who are not. Similarly, I show that PDMPs have a broad-scale impact on opioid use disorder outcomes for the full sample as well. Here again, you can see an impact on reducing opioid use disorder rates that you can see relatively quickly appear after the law's introduction and persist for 4 years or longer. Again, this is the full sample, and I haven't done anything with risk scores yet. The next thing I do is I stratify my sample into 2 cohorts according to their risk score. I use a 98.5 percentile for dividing the 2 cohorts into what I call a targeted and a non-targeted group. The targeted group is who the algorithm says should not receive an opioid prescription, whereas the non-targeted group is given a green light by the algorithm. First, I look at the probability of receiving opioids. What I find is that both the targeted group and the non-targeted group see their prescribing reduced after PDMP introduction. But the relative risk reduction in the targeted group is considerably higher. Clinicians are behaving similarly, according to these results, to what the algorithm is recommending they do. They are targeting the targeted group for greater reductions in opioid prescribing on a relative basis relative to the non-targeted group. But interestingly, I find that the non-targeted group and the targeted group have very similar relative risk reductions in their probability of developing opioid use disorder. So this is the outcome of interest that we care about. To highlight more how a policymaker might think about this result, consider a hypothetical opioid reduction policy that has causal effects on the same order of magnitude as the quasi-experiment documented here. The policymaker may only implement this experiment for one of the 2 groups here. Using the estimated point estimates, we can calculate that for the targeted group, a 0.25 percentage point reduction in opioid use disorder on 1 million people yields 3,000 cases of opioid use disorder that are averted. Instead, consider if they took aim at the non-targeted group, the group with low risk scores who have been given the green light to receive opioids. If they targeted that group instead, the group that the algorithm says are totally fine to receive opioids, they would have averted nearly the exact same number of cases. It's a much lower percentage point reduction, but on a much larger group of people. The equality across the 2 groups here is what the similar relative risk reduction measure captures. So the policymaker here is not well guided by the algorithm if their goal is to avert cases of opioid use disorder. They could choose either group, or they could go with a coin toss. Further, these results suggest you may actually have more bang for your buck in reducing prescribing to the non-targeted group. A small reduction in opioid availability yielded the same effect in that group as a larger and more costly opioid reduction for the targeted group. How should we think about this? Roughly, we may think of the non-targeted group as being your wisdom tooth or broken arm patients. Though they have very low absolute rates of opioid prescribing and therefore very low rates of opioid use disorder problems, there actually seems to be a relatively large response inside this group to having their rates of opioid prescribing curtailed. In the previous slide, I calculated a very rough implied treatment effect that captures this result in a number. The implied treatment effect being larger for the non-targeted group implies that if non-clinicians prescribe the same number of opioids but reallocated from targeted to non-targeted, the implied treatment effect implies rates of opioid use disorder could even rise. I conduct the same exercise looking at 10 strata, finding the exact same result. The further you are in the risk score distribution, the more the machine says you should have your opioid prescribing reduced. But if you actually look again at the stratification and risk score in terms of the reduction in opioid use disorder outcomes, you see no relationship whatsoever between the risk score generated by the algorithm and improvements in opioid use disorder outcomes. The algorithm is not delivering further actionable information to clinicians compared to what they are actually doing. Again, they are behaving similarly to what the algorithm recommended, but there does not seem to be any relationship here between risk score and outcomes. To conclude, I have trained a machine learning algorithm to predict opioid use disorder that mirrors algorithms that are currently being deployed into clinical practice as treatment support for doctors. The social value of these algorithms will depend on whether the estimated risk score is correlated with the heterogeneous treatment effects of receiving an opioid and the cost of misclassification of both false positives and false negatives. I plug machine-generated risk scores into a quasi-experimental setting to investigate whether they are correlated with heterogeneous treatment effects, which I argue is the object of interest. I find that the machine-generated risk scores by this machine learning algorithm that mirrors those used in currently in practice and in the literature, I find that they don't correlate with what I argue are the objective interest, these heterogeneous treatment effects. If anything, if doctors were to reallocate prescribing to become even more concordant with risk scores, we might see OUD rates, opioid use disorder rates, actually worsen. In terms of fairness, the key concern here recalls our feature importance table. People targeted by the algorithm have complex pain conditions. They may be disabled. And the cost to this group of sick and disabled people of getting the opioid prescribing decision wrong may be quite high, as this group may most need effective management to live and work, most need effective pain management to live and work. Targeting these individuals for reduction when they do not receive especially high clinical value from that reduction is a potential source of unfairness that would result from implementing these algorithms into widespread clinical use. Thank you very much, and I very much look forward to speaking with you in the Q&A.